Welcome to Verified RX, your prescription for success. Brought to you by the Vizient Center for Pharmacy Practice Excellence.
Health system pharmacies are turning to outpatient infusion services to improve financial performance as margins shrink. With me today to talk about the opportunity and their program is Dr. Zinkeng Asonganyi, Director of Ambulatory Pharmacy and Infusion Services at University of Texas Medical Branch, or UTMB Health. I'm Gretchen Brummel, Pharmacy Executive Director with the Vizient Center for Pharmacy Practice Excellence, and your program host. We are here recording live in Anaheim at the ASHP Mid-Year Clinical Meeting. Welcome to the podcast.
Thank you, Gretchen, for the warm welcome. I'm humbled to be doing this with you today.
We're so happy to have you. Tell me about your background and your organization.
I'm originally from Cameroon. I started my current role at UTMB in early March 2020 as inaugural director for ambulatory pharmacy. My responsibilities include building out an ambulatory pharmacy footprint for the health system, from retail to specialty pharmacy and the infusion services. My role has grown significantly on the infusion side as we look to protect the interest of our patients, prevent leakage of infusions outside of the organization. We find ourselves battling with payers quite a bit. They just don't want to pay us anymore. They're making us work too hard for our money. It's been a fun ride.
Well, the patients are why we're all here. So
right.
I'm glad to hear that you're doing the work around this. So tell me a little bit more about what you're doing at your system around infusions.
UTMB, a 4-hospital, about 100 clinics or so health system in the southeast Texas. Galveston being our mothership. UTMB is known to be the oldest medical and nursing school in the state of Texas and has been a beacon of education in the state. Very proud of the culture and the people at UTMB. From an infusion perspective, I've seen a lot of growth over the past couple of years. When I got there were challenges in terms of how we could optimize our ability to provide care to patients, but at the same time, keep the lights on. One of the early things from a revenue perspective and, quite frankly, a philanthropic aid perspective was to build out a patient assistance program that was robust, using AI to help so that we could reach more patients who had affordability issues, especially patients on specialty infusions, oncology, rheumatology, GI, etc., etc. That started our initiatives in terms of how do we optimize infusion services. Adherence is a key thing. If a patient cannot afford their infusion, then there's a high likelihood they'll not show up for their visit. There's a high likelihood they're having to make difficult decisions in terms of whether they put food on the table or whether they pay their hospital bill. And we didn't want that when there were resources out there from a manufacturer perspective and from disease-based foundations that could help these patients. Ultimately, that reduces bad debt because traditionally in the health systems, that's amazing what you see being written off because the patient couldn't pay or it was denied by the payer. So that's how we started. And then soon after that, one of the other things I realized was we had a gap in our ability to work denials on the back end for some of these very expensive therapies. I forged a partnership with our VP of Revenue Cycle. It was the pandemic, so everybody was busy trying to take care of patients and keeping the hospital's doors open for everybody. I saw a lot of risk if we were not paying attention to our denials data. The payers don't want to pay anymore. You could do everything good, give them a clean claim with all the information, NDC, J codes, diagnosis, and everything of CPT, all of that fun stuff. And they turn around and they deny the claim. Their goal is to see how aggressive and responsive you're going to be about that denial. It's almost like, okay, we'll deny it and see if they fight back for it. If they don't fight back for it, it's a win for us. Part of my goal when I interface with Revenue Cycle and that team was to say, hey guys, we have to be more proactive about this versus reactive. What can we do up front to get a clean claim out the door to prevent all of this back end work? Another challenge we faced was resources. In a big hospital system, academic medical center, our nurses do a lot of this work on the back end. They have large queues with charges ranging from a couple of $100,000 to $50 or $100. They're obviously going to prioritize those high charge denials in their queue. So sometimes there might be a drug that you bought for $50,000 and maybe it's at the bottom there and maybe just doesn't get that attention. So that was another challenge that we encountered. We don't have enough resources, but the ROI is there. It led to the creation of a revenue integrity role that interfaces with that team. And that's really helped a lot, especially as we continue to face site of care restrictions from commercial payers and the like. So having somebody to help a denial team with different things, whether it's the wrong NDC or additional information requested or wrong diagnosis or denial due to medical necessity. This revenue integrity leader interfaces with our clinical pharmacists that are embedded in our specialty clinics to work on this, and in a sense freeing up the physician, because typically what will happen is you send it to the physician and you say, hey, Dr. Smith, we had this denial, the payer is requesting for this information, or the payer is saying it's not medically necessary. Physicians have so much to do. He can't keep up with some of the payer requests. He really has a full-time job and a full schedule of patients he has to see. So having a pharmacy team, whether it's a clinical pharmacist that's embedded in the specialty clinic, working hand in hand with this revenue integrity manager to help draft that letter. They know the patient clinically. They have a picture of the patient. And then doing that on behalf of the provider has been such a huge win for folks. And it's been able to help us overturn some denials and allowed for us to recoup some dollars that otherwise would not have been able to recoup.
Isn't it amazing when you add a pharmacist to the situation, things just get better?
Well, our skill set, especially in this space, is our largest asset, and health systems have to continue to leverage that. And I saw a health system in Florida. A resident actually is basically doing some work to show the value of pharmacy being a part of the revenue cycle team. And that resident is hoping that will turn into a job. So it's kind of nice to see that. It starts with training new and emerging leaders to understand this very complex aspect of the infusion business.
Yeah, and it is absolutely complex. So I'd like to hear a little bit more about that complexity and the logistics of your program. What does it really take for you to be successful?
For you to be really successful in this space, you have to be up to date on everything that's going on, because payers are continually changing things on us, right? Whether it's formulary drug, whether it's what is covered today, doesn't necessarily mean a couple of months from now is going to be covered by the same payer, because maybe their formulary has changed. With the increased usage of biosimilars in the space, especially in the oncology side, that's been of huge help from an affordability perspective, from a total cost of care perspective, but challenges continue to ensue because different payers cover different biosimilars, so you have to stay on top of that. It's also the inventory constraints, because if payer X prefers this biosimilar and payer Y prefers a different biosimilar, then it means you have to carry multiple different biosimilars on your shelf. So your team has to be on their P's and Q's. From one, being able to get the authorization for the right agent, whether it's the reference agent or the biosimilar agent. Then two, working hand in hand with your pharmacy supply chain team to ensure that the right agent is available in stock for the patient, so that when they show up, they're able to get the right drug. Otherwise, you could get an authorization for one biosimilar, but if you don't dispense and administer that same biosimilar, then that's a denial waiting to happen. There's complexities in that space, obviously leveraging your electronic health record and leveraging pharmacists being able to conveniently swap one biosimilar for the next, call it a biosimilar interchange. And most health systems have that now, that grants the pharmacist the ability to make that switch without necessarily having to bother the physician. Right? A lot of physicians don't really care, especially on the oncology side, what biosimilar the patient takes, because they understand the value prop of using an equally efficacious agent that is lower cost. So yeah, from a logistics perspective, access upfront is big, because a lot of health systems struggle with this too, especially when you have a cancer patient who needs to get treated tomorrow. The key is, how do you ensure when that referral comes in, you're initiating the benefits verification and the prior authorization in a very timely manner that allows the patient to be able to get started on that treatment very soon, because we don't want delays in that. So access continues to be a big thing, and the side of care challenges and having to coordinate. In terms of logistics, patient comes in, you try to obtain the prior authorization on the medical benefit side, and let's say it's not covered. It says, oh, it's covered by pharmacy benefit, or it says, oh, you need to send it out to big box PBM on specialty pharmacy. Internally, that team has to correspond with our specialty pharmacy team to try to see who could fill that prescription through our specialty pharmacy, and then we clear bag it to our infusion center when the patient shows up for their infusion. That takes a lot of coordination. And then there's some drugs that are covered on both medical and pharmacy benefit side, and then you have to make the decision, looking at the acquisition cost and reimbursement, but also patient out-of-pocket amount in terms of what's the best site of service for this patient, what's the best benefit. That requires a lot of coordination, and sometimes that's what leads to delays if you don't really have a really good system. So at UTMB, we've established that rapport and relationship where if we get a denial due to site of service, send it to the revenue cycle manager who interfaces with the specialty pharmacy team to inquire if the drug is covered under the pharmacy benefit. And if that's the case, perfect. We go ahead and coordinate with the Infusion Center to make sure the drug gets there. Challenge is if it's not covered under the pharmacy benefit and you really have to send it outside of the health system, then that's when, one, you're leaking out that referral. Two, it creates a quality and continuity of care challenge, because oftentimes when those patients go to another infusion center outside the organization, all of that data and all of that clinical activity doesn't come back to the health system. So the physician sometimes is out of the loop because he doesn't know when did they last get your infusion, or they had challenges with getting their infusion because of affordability. So that's why it's important for health systems to continue to build on that strategy piece to say, how can we help our patients? Because we know our care is better when those patients stay within the health system. And that's why health systems now are looking at alternative sites of service, whether it's ambulatory infusion suites, or whether it's freestanding infusion centers, or whether it's home infusion as well. COVID has taught us that a lot of patients do really well getting their infusions at home, in the presence of their family, in the presence of the comfort that they have at home. For immunocompromised patients, preventing them from coming into a busy clinic or hospital, is probably what you want them to do. Home infusion is going to continue to grow. You're going to see a lot of health systems continue to expand that footprint, because it's not only to combat some of the pressures from the payers, but it's the best thing to do to get patients out of the hospital. The cost of an admission or an admission day, several $1,000s, depending on where you are. If you have a patient started on a drug that could conveniently receive in the home setting, then transitioning them from the bed in the hospital to the home setting is what you want to do, because it reduces the total length of stay, total cost of care, not only for the health system, but for the patient as well. So home infusion has a lot of additional benefits besides just because the payer says they shouldn't come to hospital-based space, let's send it over there. There's a lot of efficiencies and clinical outcomes to be derived by expanding your home infusion footprint or beginning that venture.
Free up those beds and
Yep.
make the patients happy. Yeah,
That's right.
I can appreciate that. You had mentioned reimbursement a couple times. How are you maintaining or growing your reimbursement in this time of all these challenges?
Pharmacy has to be at the table when you start talking about contracts with payers. Usually that's managed by a managed care team that has visibility to that data, and sometimes it's difficult to get it. I've spoken to people across the country who have said, we just don't know what we're reimbursed for this drug. I was talking to one of my former colleagues and I said, hey, you need to become really good friends with somebody on your managed care side to understand, one, what's your payer mix? And two, what contracts does your organization have with those payers? And model it and say, are we taking care of patients who have this particular payer classification and consistently we are under in terms of reimbursements being less than acquisition cost of the drug, for example? Pharmacy leaders have to be paying attention to that. And importantly, being on the table when this contract negotiations come up, because gone are those days when the focus of a contract was largely on MRI, CT scans, deliveries, and all of that. Drugs are a huge part of any health system's budget, a huge percentage, 25% or more of the health system's budget. So it's imperative, especially on the outpatient side, where you'll be using a lot of expensive therapies, to ensure that the health system is appropriately being reimbursed for that. And then the other piece too is, how do you make sure you're buying at the lowest price possible? Or disproportionate share hospitals that have 340B have it for a reason. Being able to leverage that to ensure that you're buying the best price at all times is a big thing. And then the other piece is, if you don't have 340B, can you partner up with a wholesaler or a specialty GPO type agreement to be able to allow you to get some of these drugs at a better price than the wholesale acquisition cost, or what we call WAC price? You have to look at it two ways, the reimbursement piece and the acquisition cost, because that's how you get margin, and that's what allows you to continue to expand services in the health system and continue to provide that philanthropic aid to help those patients that cannot afford those therapies.
You're definitely bringing it all together. And when you talk about drugs are such a huge part of the expenses for a health system and also such a big part of the revenue, I think that's a big reason why pharmacy needs to have a seat at the C-suite table at organizations. And so I'll continue to advocate for that as well.
I second that. Some health systems are a little further along in the journey. I'm an optimist that with what has happened during the pandemic, the value that pharmacy has shown from a population health perspective, from improving access to these therapies, whether it's retail pharmacy, whether it's specialty pharmacy, whether it's infusion pharmacy services and the like, I think executives are taking note. When pharmacy is 20 to 30% of the health system's revenue, that's pretty significant. Pharmacy needs to be at the table for sure. Part of the strategy, working with the chief strategy officer and other leaders in the organization to protect against some of these external pressures from vertical integration and the like.
Absolutely. Where are the biggest opportunities for enhancement or growth, and where do you see things going in the next year?
If you look at the drug pipeline, everything in there is almost a specialty agent. It just goes without saying that we're just going to, as our health systems continue to expand and geographical areas expand, whether it is by merger or acquisition, you're going to see volume for this business grow. And with that volume is going to come ability to be a very strong financial steward. Whoever wins the access game, having the right payer relationships and contracts in place, and strong revenue cycle processes is really going to be successful. I see a lot of health systems continue to expand in the infusion arena. So having a leader who is very savvy in this space is going to be crucial for a lot of health systems. We're beginning to see a lot of organizations have, beyond just managers over infusion pharmacy services, now you're having folks as directors. And I talked a little bit about other sites of service. You've got your traditional HOPD infusion center, but we're beginning to see the expansion into the ambulatory infusion suites that are non-hospital based and home infusion. Those are things that we have to continue to work on and expand, because having additional sites of service indirectly helps you with access. There's only so much you can do in your HOPD. And oftentimes if your HOPD is affiliated with a cancer center, cancer regimens are pretty heavy. Those patients come in, they get pre-meds, they're on multiple drugs for their cancer. So the priority is the cancer patient. So sometimes you're trying to squeeze in a patient on a biologic for non-oncology in there, and maybe you don't have the ability to do it just because of the acuity of your cancer patients. Having other sites of service sure helps in the non-oncology space, especially since that's where the payers are trying to drive that business away from the hospital-based space to the non-hospital-based space. So having those additional sites of care hopefully would help with access, improving access, and capacity for organizations. And I think that's something folks will keep an eye on. And then the last thing I want to talk about is chair optimization. How do you build capacity? Understanding how often that chair has to turn. There's different metrics out there. For non-oncology, it's common to see maybe 3 patients per chair per day, as an example. Cancer infusion visits, maybe 2 patients per chair per day, as an example. But I think it's important, and there's some software programs out there, whether it's within your EHR or outside, to help you optimize that chair time. Because the cost of an empty chair to a health system, is not a good thing. And it puts pressure on pharmacy services to be very efficient. Let's ensure that we get the drug into the chair in a very timely fashion. That way we keep that chair turn going. One of the challenges that I've seen over the past years is, sometimes the infrastructure is such that maybe the pharmacy is a little bit further away from the infusion center. And we dealt with that at UTMB as well. Recently, we had to get a mobile compounding trailer to place right next to the cancer infusion center. That way, from a preparation perspective, once the pharmacy team had the drug ready, it was a short walk to deliver it to the infusion center. That way we can gain some efficiencies versus what used to happen before, where from the time the nurse released the order to when the pharmacy prepped it, and from the time the chemo left the pharmacy to the infusion clinic, it was already 45 minutes or so.
Yeah, and it's such an important concept about how small incremental changes can add up to those efficiencies, improving the overall system.
That's right.
Well, Zinkeng, thank you so much for joining us today to share your perspectives and expertise. I'm really glad you could join us.
Oh, thank you so much, Gretchen.
Please join us for more Verified RX podcasts. Subscribe today, like us, and send us your comments. We'd love to hear from you. Verified RX is your prescription for success and is brought to you by the Vizient Center for Pharmacy Practice Excellence. I'm Gretchen Brummel. Thanks for listening.